Hi, Jamie Davis, the Pod Medic from the MedicCast here at EMS Today 2015, and I'm here again with another one of the amazing EMS 10 awardee interviews. It's one of the things I look forward to each year when I come to this conference, is the opportunity to talk to these EMS leaders and EMS innovators. And I have Kevin Collopy here from North Carolina. And why don't you tell us a little bit about your background and where you're from, and then we can talk about your award.
Sure. I've been in EMS for about 15 years now, and started when I was an undergraduate in upstate New York. And after I graduated, had my paramedic by the time I graduated, and ended up moving back to Wisconsin while I tried to figure out what I was going to do with the rest of my life, and took a job working part-time as a paramedic while I figured that out. Ended up going full-time, ended up getting into flight medicine, and about 3.5 years ago I moved down to North Carolina when I had the opportunity to become their full-time educator. I had been doing a lot of education on the side before I moved down there, just as in writing roles and different teaching roles, things like that, and got the opportunity to put it all together. And it was a combined role with full-time education as well as performance improvement and quality assurance.
Fantastic. So first of all, congratulations on your EMS 10 award. It's a great, well-deserved honor. And I want to talk to you about your program, your code sepsis program that you put in place.
Sure.
Because that's what you received the award for, and it's not something that EMS people might necessarily have in their system, but it's something that's more common in like a hospital setting.
It is, and to be perfectly clear, we were not the first ones in the country to do it. There are some awesome people, and in fact, one, if not two people previously received Innovator Awards for code sepsis work. Ryan Mayfield out of Colorado, the Denver area in Colorado, was one of the first to do it, and he's really been a pioneer. And what he showed is, if you have early recognition and early activation at the hospital, alerting them that you are suspicious of a patient having severe sepsis, or that is in septic shock, that they can reduce the amount of time it takes to get those first antibiotics on board and really impact patient outcomes, both their morbidity and their mortality. At our program, we're fortunate because in critical care transport we have a little bit more liberty in the drugs we can carry, and when we were looking at developing our program, we were not only looking at the 911 patients we treat, because we do some 911, but also the patients that have been misdiagnosed at outside hospitals where severe sepsis and septic shock had not been recognized by referral emergency departments, and what's frequently the case is they were in cryptic shock, so they weren't hypotensive, but they had an elevated lactate, and those hospitals did not have the ability to run serum lactates on their patients, so they were going undiagnosed. And so we've actually taken both the same quality hospital lab testing to the bedside at those referral hospitals now, and we also carry the antibiotics with us. And that's one of the big differences we saw, is if we take the antibiotic to the patient and we start it, we're actually getting the antibiotics in sometimes 4 to 5 hours earlier than they otherwise would have.
Now, you were also accredited, the first organization, EMS organization, to be accredited by the College of American Pathologists. Tell us a little bit about what went into that accreditation.
So when we were building our severe sepsis protocol, and we were looking at activating code sepsis and calling it into the hospital, what we said is, if we're going to call and we're going to change a patient who's supposed to go to a floor bed, and we're an over 900 bed hospital, so going to a floor bed doesn't mean you see a doctor the minute you arrive. So if we think they have severe sepsis at our hospital, those patients all go to the ICU.
Right.
And so we're going to change their destination. We need to be really sure we're right. And so we knew we wanted to have the ability to run labs in the back of our ambulances and in our helicopters. And when we went to our lab at the hospital, at our core lab, and said this is what we'd like to do, they kind of laughed and said, you can't do that outside of the hospital. Of course, we said, why not? Help us understand the barriers that are in place. And some dialogues back and forth. When we settled on the device we wanted, which is the Epoch blood analyzer, Alere makes it, our lab said to us, okay, that's a moderate complex testing process. I said, well, what in the world does that mean? I've heard of CLIA waived, our glucometers. They said, well, explain to me what moderate complex testing was, and they said, in our system, any hospital-based lab within our network, not only do you have to obtain your CLIA certificate for that, but you also need to become accredited. I said, okay, what does that mean? And then that's when they handed me the book of 5,000 standards and said, you have to meet every one of these. And I said, well, what about the ones that don't apply? You have to meet every one of these standards. And so that began a 2-year-long process of meeting all those standards and ultimately getting inspected and then becoming accredited by them.
And that's given you the ability to really go out there and pull together the ability to get these labs done in the back of the ambulance, so you can find their lactate levels and find out what's going on before you even get to the hospital, so you can identify these patients early.
Right, and so it allowed us to bring that data to the patient, and also when we called the intensivist and said, hey, this patient is in septic shock or they have severe sepsis, their lactate is 5.6 or 7.2 or whatever it might be, they would know that it's not some number they can't use. We adapted a program and a process that uses the same lab methodology as our hospital uses, so we're actually able to save the patient and the hospital money because they don't have to repeat the tests. So for each patient we run a lactate on, it costs us $20 to run the test when you factor in all the training and everything on the backside. Well, at the hospital, that would have cost $800 to $1,200 for the hospital to do. They no longer have to run that baseline test, and they can use ours. Being accredited allows the hospital to take our data and actually transfer it right into their database rather than having to repeat their tests over again.
Which is, that trust level comes into play there, with the hospital trusting EMS to do it, and that accreditation has built that trust level up for you.
Exactly.
So for the EMS provider out there who doesn't have access to all these high technologies, let's kind of back up a step. Maybe they want to try to do something that gives them a better ability to recognize sepsis in the back of their ambulance. Are there some steps they can take to help their system, and maybe even an individual provider, to help recognize sepsis even if they don't have the ability to pull these labs?
Absolutely, and in fact we've got a fleet of BLS and ILS ambulances that are empowered to alert our emergency departments that they have sepsis patients. And sepsis is really quite simple in many cases to identify. Anytime you have a patient who you have a known infection or you are highly suspicious has an infectious process, you want to look for your SIRS criteria. So any patient who is tachycardic, tachypnic, typically defined as a heart rate over 100 or a respiratory rate over 20, that right there would meet SIRS criteria. We can also look for hyperglycemia in the non-diabetic patient. So if all of a sudden your patient is hyperglycemic, that is 3 of the 6 criteria you might find in SIRS patients. The other things we're looking for: elevated white blood cells, elevated carbon dioxide levels in the bloodstream. They're not necessarily going to have that data, and unfortunately there's not a good reliable correlation right now to a patient's side stream CO2, which would be the natural, can I look at that? There's not a good correlation to what their side stream CO2 is to what their PCO2 would be in the bloodstream at this point. I do think we will get there. So if you have a patient who meets SIRS criteria, the question then becomes, are they in severe sepsis? Severe sepsis is any patient with sepsis who either has an elevated lactate greater than 4, a venous lactate greater than 4, or a low blood pressure less than 100 systolic after you've started fluid resuscitation. So you give them the first 20 milliliters per kilogram of fluid. If their blood pressure is still low, they are in severe sepsis. If after the second liter their blood pressure still hasn't come up, that then becomes septic shock. And you really want to hit the severe sepsis patients. That's where you get the most bang for your buck.
Yeah, and for anybody that's never managed a sepsis patient, it's astounding to me, at least it was the first time I saw it happen, the amount of fluid they could take and still not show any kind of improvement in blood pressure.
Right, and it's amazing how quickly they can become sick. And this is where it becomes so important to recognize sepsis patients before they develop severe sepsis, get those first antibiotics on board, and prevent them ever from going down that slide to becoming severe sepsis or septic shock. Because it's much harder to treat a patient in septic shock than it is in simple sepsis.
Right.
I hate calling it simple sepsis, but that is kind of what it is.
Differentiate between different levels of sepsis, I think, is important.
It is, and that's why it's so incredibly important, and I'd encourage every EMS system in the country to develop a protocol or a guideline that allows them to recognize and work with their hospitals to trigger them to start treating severe sepsis. Because so say you have a 15-minute transport. This is a great example, and someone says, well, what difference am I going to make in 15 minutes? As soon as we get to the ER, they can give them that drug. Well, no patient gets a drug the minute they walk into an ER.
Absolutely not.
And if we don't alert them and clue them in, it might be 15 minutes for your transport, 10 minutes while you're waiting for a bed in a good ER. In a lot of ERs across the country, that could be 30, 45 minutes. Now the nurse has to complete her assessment or his assessment, and then the doctor comes in and he or she needs to evaluate the patient, and then the order goes in for the antibiotic, which has to go to pharmacy. You can immediately see, well, that 15-minute transport, it could be another 2 hours before they get those antibiotics. What Ryan Mayfield showed is if you alert them, you can narrow that down to less than half an hour, in some cases 10 to 15 minutes before those antibiotics are given. And that was really profound. And I don't think it's unreasonable for the severe sepsis patients for EMS systems to start carrying the antibiotics. Most places use the same frontline antibiotics, either vancomycin or Zosyn, as their first drug in severe sepsis. And Ryan actually presented some data today at the research forum that the incidence in these patients, in severe sepsis and septic shock patients, the incidence of allergic reactions using these antibiotics is well under 1% inside of the hospital. And so that's patients who have never had those antibiotics before. That really cements the point. There's no reason that these drugs, when we carefully give them to the severe sepsis patient, should not be given outside of the hospital. We've been doing that now at our program for 2.5 years. We cut mortality in the severe sepsis patients from 47 to 14%.
That's amazing. That's amazing.
Averages 20 patients per year who walk out of the hospital who otherwise would not.
Fantastic. One last question. EMS 10 is a great award system to date. We've recognized people like yourself who are innovators in EMS for different reasons for programs they do. And it's not just about recognizing medical directors, but also paramedics and educators like yourself. Why is it important that we continue to support and engage people in recognizing people like in the EMS 10 awards?
Well, first, it's incredibly humbling to be recognized. No one sets out working on a project because they want to be recognized in the end. We also, in our industry, don't do a good job recognizing the good work people do day in and day out. We have to practice perfect patient care every day, every week, every year, day in and day out, in a far from perfect environment. And that in and of itself is award-worthy for the guys and girls that are doing it day in and day out. If we don't highlight and have forums to highlight the best practices that people are innovating and developing and the ideas people have, at some point people are going to stop brainstorming their own ideas. And what's incredibly important, I think, as a leader, whether you are a formal leader in an organization or an informal leader because you just are passionate about making people better, we need to celebrate the good ideas people have and encourage them and give them opportunities. I only got where I was because someone gave me an opportunity. If I waited for it to come to me, it never would have happened.
Yeah. Well, fantastic. Kevin, congratulations again.
Thank you.
We thank you for your continued efforts. I know this is not a one-stop thing. You're continuing to improve and innovate within Code Sepsis along with the other people around the country that are doing this. And we ask you to keep going so that we can continue to build on these best practices.
Well, thanks. It's a disease process that is not going to go away, and that we really EMS can truly make a difference in the severe sepsis patients. It's one of those areas where as we get more and more programs treating it, we can truly see a difference in our systems and in our patients and have a true impact in those patients' lives as an EMS provider.
Great. Well, I want to thank all of you for checking out this segment here from EMS Today 2015. I'm Jamie Davis, the Pod Medic from the MedicCast, and we will have more segments like this both at emstoday.com, jems.com, and of course at the MedicCast, so stay tuned.